So I guess people like the intranasal more so than the rectal from anecdotally. So um, any questions about treatment there? So other things, so these are going to be our more specific seizure causes. So sodium being low, we're going to be giving hypertonic saline. If they need sugar, give them sugar. If we're worried about, this is going to be our, eclampsia is going to be our pregnant patients, or maybe someone who just gave birth a week ago. These patients will get magnesium relatively quickly. It's usually 2 grams or so over 5 to 10 minutes. And then pyridoxine. So this is a more kind of nuanced, rare treatment, I guess, of seizures. And this really would only be considered in someone who's got a tuberculosis history, who is on a medication called isoniazid. But I don't know that I'll ever see this in my career. Hard to say, but I have not yet. The treatment for that is pyridoxine or vitamin B6. And then, if their temperature is 106, 107, and that's why they're seizing, then we'll cool them off. So this is the chart that I was telling you guys about that has some features that would make us, think more of kind of true epileptic seizures versus PNES is going to be our psychogenic non-epileptic seizure. So this is our more functional, non-life-threatening variety of seizures. So the up in the kind of timing category, I thought was pretty interesting. And I've certainly noticed with more people around and occurring specifically in the physician's office. Like I don't know how many times a patient will come in after a seizure. They had a seizure in the field somewhere. It was a true seizure, and I really have no way of knowing outside of what I hear from you guys or what I hear from family or maybe that's it. Maybe they don't seize again, and those a lot of times are the true seizures. It's really nothing or not a whole lot to do with the actual seizure, but just preventing something else from happening. So like as we mentioned before, we try to lay them on their side. The big reason we do this, if they do vomit, we don't want them to aspirate all of that and get very, very sick. So that's one of the big reasons that we put them on their side. If they're standing or in a spot where maybe they're going to fall and hurt themselves in that way, you can try to lay them down as safe as you can. The Alabama law is that seizure patients must be seizure-free for 6 months before driving or operating a vehicle. Interestingly, we physicians are not required to report patients that come in with seizure activity. So I tell people, you need to see your doctor. You cannot drive a vehicle at this time until we can figure out kind of what's going on, what's causing your seizures. Just as, for obvious reasons, that can be very unsafe. If they go home and drive a car, have another seizure and wreck. And so, not only for them, but for someone else as well. And then a lot of these patient education pages will say to call 911 if the seizure lasts more than 3 to 5 minutes. If they don't wake up, if they have two, if they're pregnant, or if it occurs near water. That's another big one too, especially with it being summer. Patients with seizure histories, just mentioning to them, if if you've been off medications or if you've had a seizure recently, you really shouldn't be swimming either. That you're at very, very high risk for drowning if you have seizure activity while you're in water or near water. Those are kind of the big ones to mention there. Does anyone have any seizure related questions? Or I guess anyone online? So next we'll have kind of 2 more unique neurologic, maybe more rare neurologic issues. The first one being Guillain-Barré. So this is acute immune mediated demyelinating polyneuropathy. So basically what this is someone will have an infection. So say it's a respiratory infection. A lot of times classically it'll be like a bloody diarrhea that they had a week ago. And then they start to develop mostly weakness, but they can also have some sensory stuff, but mostly weakness that starts in their toes and then their feet and then their legs, and it just kind of rises. So that's what this definition is describing. A classic offender, the med school classic test question answer is Campylobacter jejuni, which is basically just a viral diarrhea, viral cause of diarrhea. So that's probably the most common. I've seen one or two, maybe two cases during residency so far, so 2 in 2 years. Only 100. It's fairly rare. 100,000 cases worldwide. This can be actually a very tricky kind of thing to diagnose as well. So classically, this is going to be something like I said. It starts in their toes, and then over the course, it's quite variable, but it can be from days to weeks. Rises, the weakness starts to rise. And I meant to take this out. I was told it's extraordinarily rare for this to start near your fingertips. It always starts in your toes. Reason being is it affects the longest nerves in your body first. So unless someone, I suppose, has longer arms than legs, which possible, but anyways, a lot of times it's going to be in the toes. Progresses over days to weeks, usually at about 4 weeks. Maybe they're starting to have trouble with breathing as well, and that's going to be the big reason why I wanted to mention this is and why it can be an emergency is maybe someone doesn't go see a doctor and they have this and this is what's going on. If you have delayed onset or maybe we were unable to pick up what's going on and then it rises all the way up to approaching their diaphragm and lungs and heart, and that's when they're going to start to have trouble. They're going to start to have breathing trouble. 70% of these people will have again kind of heart and lung territory. This is a clinical diagnosis, so history being very important here. You can get a lumbar puncture on these patients. There are some, again, like test question, textbook findings. The big thing, they're going to have elevated protein that can just kind of help clue you into what's going on. And then complications list here. So really just the big one again being kind of respiratory problems and cardiac dysrhythmias. So once that rises to heart and lung territory, that's when we start to have a little bit of trouble. So up to a third, from what I was reading, up to a third of these patients end up needing intubation or respiratory support, which is why I wanted to mention it. The other thing to mention, so when we do intubate or go to intubate these patients, we try to stay away from succinylcholine or RSI. I have a chart here. It's kind of small. I'm sorry, it's small, but these patients are at very, very high risk for developing life-threatening hyperkalemia with succinylcholine. That's one of the indications, or excuse me, contraindications for using that medication. Reason being, basically, it's the way that the nerves and receptors work, and you get a huge efflux of potassium when Sux is our depolarizing drug. So when that depolarizes the area, you just get a ton of potassium release. And I actually have seen this can also happen with ALS. I have seen someone give succinylcholine in a patient with ALS. And you could see on the monitor within probably 20-30 seconds had the classic like hyperkalemia sine wave. It was impressive. And then after we gave him calcium, he improved within another, I don't know, 30 seconds. It was very, very quick, but certainly a big deal and something to consider if we're going to be moving towards that. And I think a big reason, honestly, why a lot of these patients do get intubated is because of that delayed recognition of what's going on. Because it can be a weird story. Maybe they don't really even know what's going on. A lot of people, I personally probably wouldn't be able to give a very good timeline either. So I can't fault anyone, but getting an accurate story and trying to figure out what's going on can be tough. And if they don't go see anyone for some time, it can really progress fairly quickly. Another thing we get, it's called a NIF. This can kind of help determine if they're having trouble breathing or having some respiratory dysfunction. Basically, all that is, they more or less will take a straw and have them, and how well they can do that is essentially what we're testing. And we use these numbers as kind of a measure of how well they're able to kind of suck in. These patients ultimately will be coming to the hospital and getting plasmapheresis or IVIG. That's a more nuanced kind of neurologic thing that we don't do a whole lot of in the emergency department. Yeah, I think that's what I want to mention there. So that is one more rare thing that we see. Another one is myasthenia gravis. This is probably equally as rare. I don't know the numbers, to be honest, but this is somewhat rare as well. This is going to be our patients. So basically, what this disease process is, essentially an autoimmune uh, issue where they, with any muscle contraction, you have nerves that go down to your muscles. Your muscles, your nerves say, muscles, you need to work and contract. With this, at that connection, antibodies have depleted your receptors and whatever may be, and kind of impair that connection. So these people will start to have muscle weakness with sort of increased repetition. So they'll have like fatigable muscle weakness, basically. More common in women in kind of 20s to 30s, and then it's a later onset in men. Associations with this thymoma. So that's basically just a thymus gland, that we have as children that typically, regresses in a lot of people. Sometimes you can have persistence of that, and this can be associated with myasthenia gravis. Also lymphoma, and then autoimmune disease. So this is really just the, with any autoimmune disease, if you have one, you are at risk, for whatever reason, maybe your immune system is hyperactive, or I'm not sure there's a great answer as to why it happens, but you're certainly at risk for having other things going on. So, a patient with lupus or rheumatoid arthritis, maybe we're starting to think about, oh, okay, maybe this could be going on as well, since it does have the kind of autoimmune feature to it. So this is going to be, again, this is a primarily involves weakness. So this is going to be a skeletal muscle issue, and this is going to be something that, it's going to be worse at night, better in the morning, because as they just have muscles that fatigue very easily, very quickly. It's going to be something that if they take some time and rest, that their symptoms should be better. They should be able to use their muscles kind of normally. And then it can be asymmetric as well. A lot of times this is going to be kind of, if you contrast it with the Guillain-Barré, which starts in your toes, a lot of times this is going to be proximal muscle weakness more so than distal. I have a picture here of the eye. So almost 80% of patients that are having or that have myasthenia gravis will have ptosis, which is basically just this kind of lid lag picture as described by the before photo, but they'll have ptosis, and the theory is that muscle works a lot kind of throughout the day, so it very easily fatigues with this when they have trouble with that impairment or with that. So there's something called an ice pack test, which is what this picture is basically portraying. So basically what that is, it's kind of interesting. It's just kind of a fun little bedside test. But if someone has ptosis, they have this lid lag, you can have them hold an ice cube on their eye for like 3 minutes to 5 minutes, and then afterwards they should look like this. So it should improve after the ice cube's been on there for 3 to 5 minutes. And there are a couple theories as to, I'm not sure that it's been determined as to actually why this helps, but it's a pretty classic myasthenia test. And a few theories. The one that made sense to me was that with the colder temperatures, it basically just decreases the metabolic rate, so the muscles aren't working as hard, and with that, the muscles are able to kind of work appropriately. So it's kind of an interesting little test. I've never done this, but guess I could. Why this is an emergency, similar to Guillain-Barré, with that one we were worried about once that virus, or once they start getting trouble with their diaphragm, heart and lungs, they have trouble breathing. Similar with these patients, they can get what's called a myasthenic crisis, where they have respiratory dysfunction, they have trouble breathing as well. And this is, this can be very scary too, because again, it's a fatigable illness. So if they're working hard, and the more they breathe, the kind of worse off that they're going to be. A lot of times this is going to be in the setting of maybe they have something else going on. Maybe they have an infection of some kind that triggers a crisis. Maybe it's a new medication they just started. They just had surgery. They're pregnant. Pregnancy and infection probably would be kind of the more common. I've seen a few cases of this as well. One of them was pregnant. One of them had an infection. So, but I did put stars at the bottom here. I also wanted to mention, just because someone says they have a history of myasthenia gravis does not mean that's what's causing their shortness of breath. We're going to be the treatment, at least initially, for until we can do steroids and IVIG and some other things for them. But for our purposes, it's going to be BiPAP. And we check FEC in these patients, as well as that we do the kind of inspiratory test as well to see if they're able to kind of truly breathe like they're supposed to. So that is those. That's all I have for those two more rare disorders. And then we'll kind of jump back in. So seizure being common, two pathologies in the middle being rare, and then now we got headache, very common. So 90 to 95% of the time, headaches that are going to be coming in, maybe not quite that high, or maybe higher. We'll say 90% of the time, patients are going to be coming in. They're going to be having, tension, cluster, migraine, viral illness. A lot of times it's going to be something that's not serious or emergent. We'll go through each of the kind of emergent causes sort of one by one. They're not all deep dives by any means, but should you guys have any questions about any of them, certainly let me know. So we'll talk about hemorrhage. We'll talk about subarachnoid, subdural. We will talk about meningitis with first CNS infection. We'll talk about a little bit about brain tumors, venous thrombosis. Carbon monoxide is, can be a particularly interesting one, an important one for us. And then glaucoma and temporal arteritis. That one's a little more rare as well, but we'll finish with that. And then I have some, I don't know what timing wise, but have some videos if we have time. If not, then that's okay. So when we talk about headaches, these are going to be our red flag. If patients are mentioning these, if it's a new onset, we'll try to figure out what's going on, maybe do a deeper investigation. Especially if it's new onset in someone who's elderly. If you're 65, 70 years old, you should not be developing to pay attention to. Certainly if they have anything abnormal on their exam, if they are, they said the headache was, at its most severe, it was terrible, worst headache of my life when it started, that's when we're going to start thinking about maybe a subarachnoid hemorrhage or a bleed. So that's certainly a red flag. Immunocompromised, again, that's when we're thinking about, maybe meningitis. Multiple people in the same house. So carbon monoxide, if everyone in the house, in theory, should be having trouble. If one person's having trouble and that's what's going on and that's what's causing their headache, other people should be having trouble as well in the same house. Pregnancy and clotting disorders is when we're thinking about kind of the venous thrombosis. They could be at risk for that when they're hypercoagulable. And if they're having trouble with vision, that's typically a concerning feature. You can have ocular variety of migraines. But with eye pain in general, you should be, that will raise an eyebrow, and we'll do a little digger deeping. So going through one by one here. So subarachnoid. So this is going to be, right when it started, whatever they were doing. Maybe they were sitting on the couch. Maybe they were exerting themselves. Maybe they're cutting the grass or something. 20% or so are doing something, and then have this sudden headache that's terrible. And in my experience, a lot of these, when it's serious enough, you can maybe tone their headache down a little bit, but they will never say, oh my gosh, my head doesn't hurt at all anymore, in my experience. Very, very severe. And this has a pretty, quite a high morbidity mortality to it. A lot of these patients will be very nauseated, if they're able to talk to you. Sometimes they'll be, comatose or altered, or but they will have nausea, vomiting, worse pain with light a lot of times. The The crazy thing is 50% of these can have a totally normal neuro exam. Um, and then I have a picture here. So the white is not supposed to be there. So all that's blood. That was taught to me as the star of death. So that's a pretty ominous. That's a bad subarachnoid bleed right there. That's someone who's not. That's someone who's probably they're probably intubated. I would say that's pretty high likelihood they're intubated. They weren't able to give any history. They were altered from the get go. They had a low GCS from the get go. So this is called a Hunt Hess. This is just something that we use to sort of classify these subarachnoid hemorrhages that come in. It's called a Hunt Hess grading system. But if you notice, like I said, the mortality is very high. Even someone with a mild headache and they look fine, they're already at 30% mortality. And then once they develop a neuro deficit, so maybe they're having some arm weakness, their mortality jumps to 50%, which is, I know I'd mentioned this, I guess, last week with this, talking about strokes. We talked a little bit about this, but the mortality is just crazy, crazy high. So that image on the last page was, they're probably a 4 or 5. So that image, they're at 80, 90% mortality. That's a big deal. So next one here, we got subdural. So this is going to be again kind of the white around the periphery of the brain there. That's our subdural. That's not supposed to be there. And then you can also appreciate some shift with this one in that image as well. So those ventricles should be in the center. There should be a straight line kind of between the two. This a lot of times is going to be someone who had a fall. Maybe it was a couple days ago. Maybe they've had a chronic subdural, or maybe it just happened. Elderly are going to be at risk. Our alcoholics are going to be at risk. Reason being, so with those two, in those two patient populations, you can get some brain atrophy, essentially. And when that happens, the veins that are connecting the edge of the skull or the skin to their brain really start to stretch out and become very easy to shear or rip. So those two patients are certainly at high risk. And then in the age of Eliquis, everybody seems to be on Eliquis these days. So that's another patient population who's getting subdurals quite often. So that's a lot of times that was our first question. Someone comes in with a fall, they say, are they on blood thinners? So certainly something to keep in mind. Next one being meningitis. So again, these are going to be on chemotherapy, maybe uncontrolled HIV or advanced HIV or AIDS. These patients, and they may not mount a proper response if they have pretty much no immune system. If they have a very advanced case of AIDS, this can be a subtle presentation, but classically a lot of times they will have fever. Their neck will be extremely stiff, and the true neck stiffness, they're gonna have trouble like turning their head to look at 90 degrees to look at the wall. It's gonna be very, very stiff, kind of classically. The light will bother them. I look in their pupils always. And that will bother them. A lot of times, and this is sort of kind of bug or bacteria dependent, but with some of the bacterial meningitis cases, they can have a pretty impressive rash. And those are going to be the ones where the textbooks will tell you that the military and college students can be at high risk. It's really just anyone who's kind of living in close quarters. It's just very, very contagious. So one person gets it, everyone's at high risk who's in the same sort of living quarters. Seizure presentation of these is 25%. Quarter of them also are having kind of a vocal deficit. These are just some exam maneuvers that we do oftentimes in the emergency department. I like the Brzezinski's better. Basically, what we're doing in both of these tests, all it is you're manipulating or kind of stretching their spinal cord or meninges and seeing if it hurts. That's basically what these tests are sort of looking at in conjunction with their neck and their legs. And is typically what we're looking at there. So next we're going to go to brain tumor. So this is going to be, again, our first time seizure patients, this is what we're looking for. It's one of the big things. You would think it would be a unilateral headache a lot of times with these patients. If their mass is here, you would think they'd have a headache right here. Not always the case. They can have a very generalized, or sometimes it's just hard to describe. And then the other reason they may have sort of bilateral or just a diffuse headache is, these patients are having increased pressure because of the mass. So you'll find a lot of times it'll be positional as well. So anything that kind of increases, bending over, classically to tie your shoes, you're getting a lot of pressure to your brain there. That's going to make your headache worse. When you're lying down all night, what we do to decrease intracranial pressure is raise the head of the bed up. So if you're lying down flat all night and your headache's a lot worse in the morning, that can be indicative of increased pressure as well. And that's when we start to think about things like this. Only 8%, this was like really crazy to me, is only 8% have neurologic abnormalities. You would think something this large, and this one very well could. This is just a stock photo, but you would think, with a mass being in a very specific spot in the brain, they would have some sort of deficit that you would appreciate, but only 8% really have a deficit. So again, that's why very important for seizures too. So venous thrombosis. So this is going to be these are our pregnant patients or anyone who has a clotting abnormality. So if they're on birth control, that puts you at high risk for having clots. If you just had a recent surgery, you're at risk. If you have if there's a family history of like a factor V Leiden is a kind of a classic clotting disorder, but some people just say, factor V is kind of it's fairly common. That impressive amount of red blood cells, so that there's just so much in there that it just makes it kind of viscous and hard to flow properly, so you can be at risk for clots. These people have vomiting a lot of times and or seizure, but vomiting is pretty classic with their headache. The image, so image A, that's more of a nuanced kind of radiologic finding that the radiology residents and or attendings will identify. But on B there, it's pointing at what's called an empty delta sign, and that's just kind of an interesting CT finding that's classic with these, but otherwise nothing to worry about. Carbon monoxide. So this is classically will be fall and winter times when people are using heaters, or maybe a wood burning stove or a heater inside without proper ventilation. So should that be the case, we can get carbon monoxide poisoning, and people plus minus having a detector that's working well. And again, if one person in the house is having daily headaches and trouble with this, and there are other people in the house, I would be, our suspicion goes way up if several people in the house are having trouble, especially if none of them have headache histories. So carbon monoxide, so odorless, colorless. These people can be altered. They can just, a lot of times they'll just describe, I have no energy. They'll be just very irritable with that headache. Sometimes it can be bad enough to where they can get seizures. They can be ataxic or have trouble walking. Kind of hard to say just based on the degree. These patients, their pulse ox is going to be normal, just the way that the carbon monoxide takes over the hemoglobin. The pulse ox on their finger is going to look normal, so that will not deter us for investigating carbon monoxide. We'll have to this is someone will get a venous gas with a carboxyhemoglobin on it to look at it. And looking at carboxyhemoglobin numbers, so smokers, a lot of times we're starting to get worried about carbon monoxide poisoning when we get in the range of higher than 10%. Kind of 10 to 15 is where we start to suspect that's what's going on. Maybe even less than that in non-smokers, but um, smokers can have a carboxylamine level as high as 10%, which is quite impressive. Basically, what we do for these patients is give them oxygen, and they should that should help them quite a bit. We do also over at UAB, we have for the cases that are very severe, we can take them to the hyperbaric oxygen chamber. So people who are altered or confused, or they syncopize, they have seizure, coma, pregnant patients, if they're greater than 15, that can certainly be bad for baby. So if they're having numbers greater than 15, we will talk with our hyperbarics people about that. And then anything higher than 25%, that is severe enough to where we'll talk to them about going to the chambers as well. This is what it looks like. I haven't been in it. I've been asking if they'll let me get in it to see what it's like. So I can't tell you what it feels like, but maybe one day if I come back. Next one we got here, I think we have 2 left. So hang tight. Glaucoma. So the textbook will describe this pathology as a mid-dilated fixed pupil. So if you notice the eye on our right, but patient's left, is what our glaucoma is going to look like. You see if you notice the pupil is a different size, and if you were to shine a light in there, it really shouldn't react a whole lot. It should be kind of fixed in that spot and size. You'll notice the conjunctiva is very red as well. Those are 2 kind of classic findings with glaucoma in patients, who are coming in with a bad headache. They'll probably also be describing visual troubles. Classically, it's anytime they see a light, it's going to have like a peripheral haze around it or like a halo. That's what's described. And this is something that happens very quickly. Whether it's maybe they start a new medication that or changes the way their pupils dilate, or maybe dilates their pupil, or another classic med school test question is, they go into a movie theater, and when you go into the movie theater, there's not as much light going into your eyes, so your eyes dilate, and that can sort of trigger a glaucoma episode. And the other thing to mention, this is acute angle. You can have acute angle closure glaucoma and then open angle glaucoma. For our purposes, we'll just call it glaucoma, but this is the acute angle version. They'll have very high eye pressure, so we'll take our little tono pin and tap on their eye to get an eye pressure. It should be less than 20, but these patients it'll be almost 3 times the limit of normal. This is actually fairly rare. I don't know that I've seen a good true case of this in residency to date. And then this is our last one here. This one's also quite rare. I have seen this actually. It's called temporal arteritis. So this is a lot of times going to be someone who's coming in with a headache. Maybe they're a little older. A lot of times it's going to be someone who's female, and they will have visual troubles. They'll describe maybe some blurry vision a lot of times. But they'll have a unilateral headache, jaw claudication. So, maybe when they notice when they're chewing, they're having a lot of trouble, a lot of headache kind of right here, kind of right near their eye, on the side of their eye. And like I said, it's a lot more common in females that are greater than 50, which is actually part of the diagnostic criteria. But the big exam thing that I do for these people is their temporal artery runs right here. A lot of these patients will be very tender because they're having essentially an inflammatory process on that artery, so they'll be very, very tender if you touch their forehead there on the side. And then going through the diagnostic criteria, so they have to have 3 of these. So it's pretty. The gold standard is this number 5 here. The abnormal tab is a temporal artery biopsy. So the gold standard in the textbook is to biopsy that artery, and they put it under a microscope and see if that's what's going on. Otherwise, so in someone who's 50, they're coming in. It's really hard to say new onset headache because when you ask a patient, what is this a new headache? A lot of times, everyone's had a headache at that point. It's hard to say if it's new or not, if they can describe that it's a new character. But if they're greater than 50, they're having a new headache, I'll get an ESR on these patients with just a blood draw. And if that's high, then you're meeting criteria right there for diagnosis, which is pretty crazy. And really just the treatment for these patients is steroids. The reason that this is a big deal and a big emergency, and something we talk about with headaches, is if they start to have visual loss, the visual loss is permanent. And the treatment is really just steroids for some time. So there's not a whole lot of risk to treating them. But there's, if you miss it, that's a big deal because they're going to lose vision on that side. I think that's all I had to mention there. I don't know if this will work. We can try, I suppose. Oh, very, very small. Awesome. I thought that was going to maybe open up to be larger. Here, let's see. Yeah, that's very. Can you all see that? Do you want me to just get out of this and make it bigger? Let's just do this. Can I just do this? Will this be okay? So this is, I just wanted to show kind of what a true seizure looks like. Is that sharing? Maybe. It says that I'm sharing. So this is pretty classic here. Wait, actually. So here you can see, he's got the kind of the extension and flexion of his hand there. I'll just play this again. This is the part that I like the most, these two. So it's hard to tell here, but his eyes deviate to the side. And then, yeah, this guy, so he's got very, very much rhythmic movement of that left arm. He obviously can't, answer questions or anything. This one here, very, very stiff. That hand right here, this kind of flexion maneuver is pretty classic as well, with the seizure activity. That was the big thing I wanted to mention there. And they're both very short. I know these are just kind of small clips, really, but those were the two I wanted to mention on that. And let's go to the next one. Sorry. I thought when I clicked these videos, they would just pull up in YouTube, but we'll just work with it here. This one's very short as well. So this is a functional seizure that we're seeing. So he's got a lot of kind of side-to-side head movements, which is something to notice here. It's very, really his whole body is kind of side to side.
Yeah, we had a few questions come in. One was a drug question about headaches. Is there a difference or a preference between opiates and tramadol for headaches in the pre-hospital setting?
Yeah, we're not using tramadol for one. So I would not do opioids for headache at the pre-hospital setting unless there's trauma involved and you're treating other injuries.
Yep. Okay. Very good. One's a little kind of off the wall, but I'm going to ask it. Will a headache resulting from hitting head during the fall increase blood glucose?
Yes, you get a stress response from any kind of trauma or injury, so you will get an increase in your glucose. That's a reasonable question. Yeah.
So really that can happen with any
Any
traumatic
stress.
injury.
Yeah, it could be, fear, anxiety, or trauma. Yes.
And then we had a couple of people mention, I'll let Dr. Ferguson kind of address this, that, when you were talking about seizures, you mentioned midazolam at 5 to 10 milligrams IV IM, but actually here in Alabama, our dose is much lower than that protocols. And kind of to complicate that, which a lot of people were texting me, telling me they only have midazolam in 2 milligram vials.
Yeah, so I think the state's looking at revising the protocols. Currently, it's 2 milligrams IV for medics, IN for advanced EMTs, and I think the plan is to move it to IN or IM for the advanced EMT, but the dose is too low, right? So, 5 to 10. For Ativan, the state says you can do 0.1 mg per kilo up to 2 milligrams. In my opinion, that's probably too low for a real seizure as well. So that's being addressed by the state right now. You could probably address it through your offline medical director and maybe potentially ask the state for a variance to have standing orders for a higher dose.
Because it comes packaged in 5 and 10 milligrams.
Yeah, you get 2, 5, or 10. So
Yeah.
it's all about the same price, right? And the only thing I want to say, we got to take a break, so but just remember for seizures, as a dispatch for EMS, always consider that as a dysrhythmia, cardiac arrest until proven otherwise. Always think about getting a 12 lead on people who are post-ictal after a seizure, after you're managing their airway, you do oxygenation, inhalation, you check your glucose. When they come back, 12 lead. On QT, having runs and short stops, that's the problem. And if you miss that, people die. Take a quick break, and we'll come back in about 5 minutes.
Yeah, everybody will be gone here about 5, 6 minutes, and we'll be back with Dr. Wade. So stay tuned.
Let's see.
I'll tell them to come back and we'll get started.
Cool. All right. Oh, yeah, you're fine. No, I appreciate it, y'all. And I mean, Chris knows I maybe wrote a couple minutes behind. It's no big deal. Yeah. Yeah, he don't care. He's fine. Yeah. All right. Just to double check on this microphone. Can y'all hear me all right? All right, we working? Good deal. All right, guys. So I guess we'll go ahead and get started. I want to apologize first off. I was initially going to do some time on renal emergencies. That PowerPoint and the computer it's on is probably on Facebook Marketplace somewhere in the Dallas-Fort Worth area about now. So we're going to lateral a little bit. I'm going to talk about endocrine emergencies today. This is one that we see probably a lot of out in the pre-hospital setting. A lot of kind of bread and butter EMS, like emergency medicine and pre-hospital medicine here. Spend a lot of time on kind of some common presentations, and then a couple of pretty rare but pretty deadly presentations, just stuff to keep in mind kind of as we're going around. And y'all feel free to stop me at any point. I try to keep a lot of pictures in my lectures just because when I start putting down a bunch of words, I start getting confused. So y'all bear with me. I have no disclosures here. I'm not getting paid by Big Diabetes, although I wish I was. Just a quick overview. I'm going to spend a little bit of time on adrenal crisis, going through kind of our diabetes, high sugars, a little time on DKA and HHS, some of our pretty common stuff. And then some of our thyroid emergencies on the end, which are kind of some of our more rare but pretty deadly presentations that we see occasionally in the emergency department and kind of out in the pre-hospital setting. As we can see kind of on the side, the endocrine system is, pretty overarching throughout the body. This is all of these systems, and you'll see this kind of reoccurring theme where it's, the brain talking to an organ that's talking to the rest of the body, and there's lots of feedback loops in there. We're not going to get too in the weeds on it though, don't worry. Speaking of, this is kind of our basic hypopituitary y'all. This is way too complex. We're not going to get way in the weeds on this because a lot of these systems are so complex and interact at every single part of the body. What I try to do is break it down a little bit more simple than that. So we've got our hypothalamus up kind of just underneath the brainstem. What this does is it acts on the anterior pituitary sitting right next to it. So releases something called corticotropin releasing hormone, acting on that anterior pituitary right next to it. That says, hey, release some ACTH or adrenal corticotropin hormone, telling the adrenal glands down around the kidneys to release adrenaline, or not to release cortisol. This baseline cortisol level within your body is really what helps kind of promote your sodium metabolism, promotes your blood sugar your blood pressure throughout the day, and can be really important in some of this. And you can see just based on kind of coming from the brain down to the adrenal glands, there's a couple different places where we can break this system. So let's start with kind of a case. You're called to the home, 32-year-old gentleman, there with altered mentation. Got Crohn's disease. Family said he had a recent flare and started on prednisone. He's been taking a bunch of prednisone daily, but ran out a couple days ago. Wasn't able to refill his prescription. He really just takes the prednisone 40 every day, mesalamine, and some ranitidine. There's your initial vitals on this gentleman. Heart rate looks okay. He's 68 over dead. Respiratory rate's pretty normal. It's at 95. He's pretty cold. When you go in and take a look at this guy, he's a little altered. He's not quite following commands. Maybe he'll open his eyes when you yell at him. You notice this kind of weird dark pigment throughout, kind of on the lines within his hands, maybe up and around his face, but otherwise looks okay. Get a point of care glucose, and it's low as well. Any of you guys history buffs out there? This guy is. So yeah, right. So JFK actually had this same disease, and what we're talking about is called Addison's disease, or a primary adrenal insufficiency. So in JFK's case, his sodium metabolism. So these guys actually have to take steroids chronically to try to keep that up artificially. This is one thing that we see not infrequently in the emergency department, and it's the problem is unless you're looking for it, you're not going to see it. The kind of overarching theme that we'll see coming back again and again and again with this is you've got one of these axes, one of these big systems where there's some kind of insufficiency, whether that's up in the brain, whether that's at the gland itself that's releasing the hormones, and then you get a stressor on top of that that really throws these guys off the rails. Most common thing, that's why I've got an underlined bunch of stars by it, is we see this a lot in people who are on chronic steroid therapy. So, you know, a lot of your autoimmune patients around here, back when COVID was going around, we'd have people on like these super, super long steroid doses. You know, maybe they talk to maybe they're shopping around different primary docs and they've had this kind of upper respiratory infection for months and months and months, and they've been on prednisone the whole time. What happens is these guys either run out or they get some other stressor on top of that that can really throw them into this crisis. You know, the other things we see is, as I was talking about with Addison's disease, that primary adrenal insufficiency, like what JFK had. Sometimes we see cancers up and around the adrenal glands, infections. The classic telling is like some kind of fungal infection or TB, although that seems to be less likely, especially around here. Within the anterior pituitary, kind of up around the brain as well, you know, same deal. Sarcoid, TB can infect and destroy those glands. If you got neoplasm, you got a big tumor just kind of pushing on that thing, it's not going to work as well. And then sometimes if we've got somebody who's got head and neck cancer and we just blast their throat and kind of their skull base with radiation, we can knock out these glands and make it worse. And sometimes we're even doing it. So you've got somebody who's got some kind of insufficiency there, right? On this chronic steroid therapy or has like an adrenal insufficiency, and they get septic or they get a bad urinary tract infection. Sometimes if they go in for surgery or if they get in a bad car accident, their body, you know, they run out of meds, which is not uncommon around here. Psychological stress, exercise, dehydration, pregnancy can throw people into these. And then all kinds of medications. I'm not going to throw up a list on here because the more I looked, it's a list of hundreds and hundreds of meds that can kind of induce this for these guys. What you'll see with these guys is they come in sick. They're hypotensive, usually got this vasodilatory shock, similar to like a septic shock that you guys will see. They're febrile sometimes, they're throwing up, they got belly pain. I had a patient, I think early last year, where I thought he had, you know, a bowel perforation, because I mean, you just kind of whisk by his belly and he'd jump off the bed on you. Turns out it was one of these adrenal crises, and this was just kind of the way that it manifested. Delirium, you know, confusion, and then they can get this kind of weird hyperpigmentation or kind of vitiligo. So, and I know some of you guys are looking like, hey, that's really not specific, which is, it is. So this is hard to pick up on if we're not looking for it. Not that it helps us a whole lot in the pre-hospital setting, but kind of some of your labs that you'll see over there, these guys will get hyponatremic, so they're just losing all their sodium. Potassium will start climbing through. The big one to pay attention to is it's not uncommon that these guys are hypoglycemic as well. So if you're seeing somebody who's shocky, altered, you get a D-stick and it's low as well, maybe keep this in the back of your brain as something that may be going on. As I mentioned, these skin findings that can be helpful with it, what you'll see is kind of on the left side right here, you've got one that's labeled May 2014. You see kind of around the underwear and panty line, you can see some darkening there in that intertriginous zone. If you're worried about it, sometimes you just, hey, take a quick look in their mouth. You might see something like this that would tip you that direction. So what do we do for this guy? Well, they're not making enough cortisone, so let's give them some cortisone. A lot of times the mainstay treatment here is just 100 milligrams of hydrocortisone. We're giving it IV, and if it's not working, give another dose. The problem is once you get that on, because they're dependent on this cortisol, you've got to redose it in about 6 hours, and another 6 hours, and another 6 hours to make sure we're keeping those levels high enough to deal with the stress. A lot of times with these guys, you know, they have a basic amount they take at home. Maybe they take like 20 of prednisone every day at home. But if they get, and they'll a lot of times will know from their doctor, if they get sick, if they get in a car wreck, if something else is going on, they need to double or triple that dose to try to keep up with the body's demand. Good thing is there's nothing really new here for us in the pre-hospital setting as far as resuscitating these guys, right? It's similar to your sepsis patient. We want to fill the tank. Let's get some fluids on board. Start pressors if they need to. I love Levophed and epinephrine for these guys. Once they get to the hospital, we'll get nerdy and we'll draw the random cortisol level. Normally, it's not doing me any good in the ER, but it's helping our ICU guys or our inpatient docs once they get upstairs to help make this diagnosis. Really, what my practices lean to nowadays is, all right, we've got somebody who's sick as snot. They're hypotensive. We've given fluids. We're getting our pressor started. We're starting to max up on our Levophed or on our epi, and we're looking to add a second agent on. About that time is when I want to kind of train it in the back of your brain. Hey, let's go ahead and give 100 hydrocort, just because if it's not going to hurt the patient getting more cortisol on board, at least in the acute phase. And if you're dealing with an adrenal crisis that you haven't diagnosed, there's no amount of pressors you're going to give that's really going to get you there. You're going to add that second, third pressor on, and you're still going to have kind of the same response. So just kind of thinking back to, hey, what level's broken? The good thing for us is the answer is typically going to be cortisol, cortisol, cortisol. Any of you guys remember this guy? So Wilfred Brimley, he had a couple of commercials back in the day where he was diagnosed with type 2 adult onset diabetes. So we'll kind of switch gears over to our diabetes. Classically what happens is you eat a big meal, right? You start absorbing all that stuff. It comes out in the sugar from the food you eat gets out into the bloodstream. Problem is just hanging out in the bloodstream. Your body can't really use it straight on. We use a hormone called insulin that's created within the pancreas that comes out in the bloodstream. It actually allows our body to absorb that blood sugar out of the bloodstream and actually use it to make energy. Unfortunately, in some people, especially kind of type 1 diabetics, you get some kind of destruction within the pancreas of those beta cells that produce insulin. And now there's no insulin floating around. Blood sugar's floating around in the bloodstream, but the cells of your body actually can't use it. So they're in this kind of chronically starved state. On the other hand, we see a lot, especially here around Birmingham and with all of our Alabama mediums around here, is this type 2 diabetes, which is more kind of this insulin resistance, where they make some insulin, but kind of hammering back on our type 1 diabetics. Most of the time, you're going to see this in kind of young people. Age of onset usually is kind of somewhere around the teenage years, although late onset that I've seen due to autoimmune disease kind of in our like 50, 60-year-olds. This is a fundamental problem of they can no longer make insulin at all. So all that blood sugar is floating around, but without insulin, they are unable to use it entirely. So they're in this starvation state unless we can get them insulin so that they can actually use that blood sugar. Unfortunately, type 1 diabetes can take a lot of years off somebody's lifespan just because it's very difficult to manage blood sugars consistently. And for most of the time, this is an autoimmune problem. definitely be a stroke mimic. And I've seen these guys get stroke alerted. Then you're not glucose, and their glucose is like 20. I'm nauseous, throwing up, feeling terrible. They just don't quite feel right. You guys do a great job of this, is using that glucose as that sixth vital sign, right? As you're getting everything, half the time when I'm getting reported, y'all are already telling me the glucose before I'm even asking for it. It's awesome. Unfortunately, on the inpatient side, we still have to keep drilling this into kind of our APPs, into our new MDs of just, hey, check the glucose, check the glucose, check the glucose. Ask for it if you haven't gotten it, because this can be extremely dangerous for patients, and it's an easy test to get, especially with kind of point of care glucose. You guys know the treatment. They're low on glucose. Let's give them some glucose, right? You have time to get IV access, that's great. If they're able to eat something, then yeah, you can definitely just get some complex carbs in, get some orange juice on board. If they are comatose, if they are seizing on you, I'd have a low threshold to go ahead, drill these guys, get some dextrose on board, because you're going to save these guys' lives just getting that blood sugar up. So kind of moving on to another case. Forget that I misspelled called on there. Spinals time. You get sent over to the UAB dorms. She got a 19-year-old female. She's vomiting, headache, belly pain. Says she's been having like some intermittent chest pain for the last couple days. Maybe sweating, feels sick, but doing okay now. She's got a history of type 1 diabetes. Initial vital signs on her. She's tachycardic, but normotensive. Looks all right. She's breathing quick though. You go in and she's kind of satin fine though. Sweaty, looks dry everywhere. Those guys where you can kind of hear their lips smacking together from across the room, kind of as they're talking to you. That kind of dry mouth. You get a point of care glucose there, and it's just reading high. I think at UAB, our start reading high anywhere above 400. I think that might be about, y'all's might be 400 or 500 when they stop reading. What this is DKA, so diabetic ketoacidosis. What this is, kind of our recurrent theme, this is impaired insulin or glucose metabolism plus some kind of stressor. Diabetics are going to be the ones who get this most of the time. By far and large, is going to be your type 1 diabetics, right? Occasionally, we can see it in our type 2 diabetics, because they are just so insulin resistant that they are functionally type 1 now. Even though there's some insulin going around, unless they give a ton of it, they're just not able to use any of it. And it's not uncommon, especially in these younger people, even 8, 9, 10 years old up into the teenage years, you'll get these new onset diabetics where, they've just been feeling sick, maybe throwing their guts up, and they're in full-blown DKA and have just never been diagnosed. You'll notice, these guys will be tachycardic, they're dehydrated, they look terrible. When it gets really, really severe, when they get this horrible acidosis, they get this high blood sugar, they can actually get some swelling of the brain in addition to that, and will actually develop some neurological symptoms, whether that's being super altered, they can't have like some focal deficits. It's just something to watch out for in these guys. What this is kind of this perfect storm of, you can't use the glucose. They're in some kind of stress state, whether that's from an infection or they're studying for finals really hard, just went through a divorce. Maybe they're dehydrated to begin with. Body can't use the glucose and it's struggling, right? It goes into panic mode. They're releasing more catecholamines. They're getting that adrenaline surge. It's causing an increased blood glucose on top of that, which makes things worse. Unfortunately, and you guys will see kind of the classic thing when these guys come in with high blood sugar is, they're drinking like crazy, they're peeing everything out, but they're just super, super dehydrated, because what happens is when that blood sugar is super, super high, your body wants to kind of overfilter and over pee to try to get rid of that stuff, but it's not able to. Because they're in that starved state, they start breaking down fat, liver's trying to kind of produce some kind of a byproduct of making energy that your body can actually use. It's not glucose, but unfortunately, it's also very acidotic. So these guys will be dehydrated, they'll be acidotic. They've got this high blood sugar. They look terrible. A lot of times you'll see these guys, and it's not uncommon that, you know, they'll come in and maybe the nurse grabs me and says, hey, you know, hey, they got this kind of weird fruity smell on their breath, or hey, maybe it smells like they might have been drinking, which can kind of be hard to distinguish sometimes. What this is caused by is actually acetone that they're breathing off. Not to get too in the weeds on this, but whenever we can't use glucose, the liver starts trying to produce other energy that we can use outside of that. And it does that by breaking down kind of fat cells through beta oxidation. And what this is going to produce are these ketone bodies, this beta hydroxybutyrate and acetoacetate. That acetoacetate, when it goes out to the muscles to actually get used as kind of almost like a bypass energy source, it gets broken down into acetone and that beta hydroxybutyrate. That acetone, you can actually it actually is soluble in the bloodstream, and you breathe it off. So they get this kind of weird fruity breath smell whenever they get it. Pre-hospital, well, what do we need to do? Well, I'd say, you know, make sure we're checking glucoses. You know, I would argue just make it your 6th vital sign. You know, if you're worried about it at all, just go ahead and get the finger stick. You know, it's a cheap, easy test, can give you a lot of good information too. Most of the time, these guys are very, very fluid down, so they need some fluid resuscitation. If you've got time to hang some fluids, you know, go ahead and get it on board. You know, O2 if needed. Sometimes it can help with kind of their work of breathing, but the main problem is they're just trying to blow off all of this CO2. It's not so much an oxygenation problem. I say prepare for CPAP and advanced airway because if these guys get severe enough in DKA, they're trying to breathe really, really hard. They're trying to keep up and blow off that CO2 so that they don't get more acidotic. As these guys get tired or as they get altered because it's getting worse, you can start to see respiratory depression, and these guys will crump very quickly. Just of note, kind of if you're CPAP is a great option for these guys because you can increase their ventilation. They can blow off more of that CO2, and it can definitely buy you some time. Advanced airway if needed. Just know that if you do intubate these guys, instead of setting them on a rate of 15, 16 like you normally would, we're going to have that rate much higher, kind of up in the 20s, up in the mid-high 20s. Really what these guys need is a diesel bolus, right? If we're anywhere nearby, let's get them loaded up, get some initial tests going, and start hauling towards definitive care because it's going to need a lot of resources and a lot more help. Kind of jumping into like some of the labs, some of the stuff that keeps us in there. In DKA, I'm usually starting with, you know, a basic metabolic panel, that beta hydroxybutyrate. It's a specific test looking for those ketone bodies, a VBG, and really all I'm concerned about is, hey, how acidotic are they, right? And then looking at their urine, maybe we'll see some glucose, some protein, and some ketone bodies in there. When you check the blood glucose on these guys, a lot of times it's high, but compared to some of the patients we see out in the community, it's not terrible, right? It'll be 300 to 500. I know a lot of patients that are just walking around there. But the problem is these guys can't use any of that sugar, period. So their pH is going to be super, super low. I've seen these as low as, you know, 6.9, 7.0. They're on the edge of coding at that point. You know, they'll have a low CO2 because they're breathing it all off. You got to watch these guys. You know, they can be hyponatremic, so sodium will be low. The interesting thing with this, and I always harp on it with my providers, is it's actually kind of a weird lab error where when there's a lot of glucose in a sample, it kind of messes with how they can read the sodium. So the sodium will read artificially low, even though it's not. So you'll have patients that'll come in, their sodium reads 115, but their glucose is 800, and it's dehydrated, they're super acidotic, and they can't use any of the sugar, right? So kind of our mainstays of this should be get some fluids, get some insulin on board. As a really important aside to that, we have to be really conscious of our potassium when we're repleting these guys. Most of these guys are total body potassium depleted just because they've been peeing it all out. And insulin, when we give it, actually drives all that potassium intracellularly. So you can actually, if you start this treatment, start running really quick with it, aren't watching for that potassium, you can bottom these guys out pretty quick. A lot of times when I'm starting it, I'm hanging fluids, I'm going ahead and hanging some potassium with it, and I'm giving some insulin. really the focus in DKA is I don't really care what their glucose is, to be honest. Really what I'm more concerned about is that acidosis and that dehydration. And the way we can fix that is really getting some fluids on board, driving some of that glucose intracellularly so the body can use it and start chewing up those ketone bodies. You know, one thing that we noted, and it's part of the, I think, Children's of Alabama protocols once they get into the ER, is if they're altered, you know, sometimes they'll even consider using like hypertonic saline in these guys. This is not to freak y'all out or not anything to try to memorize here. It's just to know that DKA is something we've been dealing with for a long time, and depending on where you're at, it's very heavily protocolized. This is, I think, the Children's of Alabama protocol from a couple of years ago, and you can see they break it into kind of different phases, but really that initial one is hey, let's get some fluids on board, let's get some insulin on board, and check your potassium, and you're just continuing that out and kind of adjusting from there. Kind of changing directions over to like our HHS. This is gonna be more common with our type 2 diabetics, right? Another, unfortunately, non-specific presentation, you know, MIMA's diabetic. Maybe she's got some urosepsis going on, recent changes in her meds. What I want you guys to remember about HHS or hyperosmolar hyperglycemic state in these type 2 diabetics is this is functionally our problem, is that gooey syrup is what their blood looks like. Their glucoses will be up close to 1,000. They are severely dehydrated. I mean, this is what's pumping around, and it's very difficult for the body to use that appropriately, especially up and around the brain. Kind of highlighting some of our key differences here, right? In HHS, our primary problem is they're just very, very, very dehydrated. That blood is like syrup. Meanwhile, on the DKA side, it's more, we have all these ketone bodies around kind of creating this acidosis. In DKA, I'm not really worried about what their glucose is. I just want to fix those ketone bodies and close the gap. Meanwhile, on HHS, I want to really control and kind of rehydrate them, and that's going to be our mainstay therapy. Obviously, with both of these, you can definitely see some cerebral edema. You can definitely see some weird electrolyte abnormalities. And then, kind of note is with DKA, this can happen pretty quickly, you know, especially if you've got somebody who's a type 1 diabetic who runs out of insulin. But on the other hand, HHS, true HHS in type 2 diabetes actually develops weeks, even up to months at a time. And the good thing with that is, well, because they got there over a long period of time, we got more time, so we can take our time with it. So kind of our mainstay of treatment there is going to be fluids. If you really want to get nerdy about it, you can even calculate a fluid deficit in some of these guys once you get some initial labs. It can be as high as 10 to 15 liters down. So they are super dehydrated, you know, really watching their electrolytes while they're there. A lot of times, we probably don't need to get an insulin drip on these guys. And it's probably not necessary to try to slam in, you know, a big dose of insulin on the way. And, you know, we can get some long-acting on board and really just concentrate on getting the fluids and getting their bloodstream a little less syrupy. So never try to keep us on time. On the throat. Think of this like the gas pedal for your body, right? So this is gonna control metabolism. It's gonna control heart rate. Can control kind of your like your internal body temperature, appetite. Really plays into a lot of different systems within the body. And we don't really have time to cover that, and I don't think it's really necessary for us. But when the system gets really out of whack, it can cause a lot of problems. This is kind of my simplified version of the thyroid axis. So kind of similar to before, we've got the hypothalamus up in the brain talking to the pituitary gland hanging off of it that releases our thyroid stimulating hormone that goes down to the thyroid and tells it to release thyroid hormone. T4 and T3 are just two different kinds of thyroid hormone that we follow pretty closely in the ER. T3 is your more active of those, and those will go and act out in the rest of the body at all different sites to basically control this. But I want you guys to think of this. This is the gas pedal for the body, kind of controlling how quick or how slow everything is moving. So kind of coming on to our to one of our last cases, think about one more after this. Family called 911, got a 45-year-old gentleman at home. He's confused, febrile, short of breath, having a bunch of diarrhea. A lot of times thinking, hey, maybe this guy's septic, maybe he's just super dehydrated, what's going on? Walk in the room, this dude's just staring a hole through you, right? Get your initial set of vitals. He's hot, 39.4 Celsius, tachycardic, breathing pretty quick. His pressure doesn't look terrible. He's sitting kind of borderline, kind of 89%. What this picture is describing on the side is called exophthalmos. It's these bug eyes where they're just sticking out. These guys are sweaty, tachycardic, tachypnic. What this is thyroid storm. So this is a severe hyperthyroid, and a lot of times can be caused by whether it be infection, whether it be some autoimmune disease. Maybe they're just taking a ton of their thyroid medication that can kick this off. The reason why this is important to keep in mind is it's got a 90% mortality no matter what we do. These guys are sick as stink whenever they hit the door. You get this severe hypermetabolism, so they're sweaty, they're febrile, they're tachycardic. These guys are super high risk for like weird cardiac arrhythmias. They can be super agitated, almost can seem like they can be on like some pathomimetics, where they're on like can almost look like an amphetamine overdose, can look like a cocaine overdose. These guys can get like weird resting tremors where they're shaking all over the place and actually can't even develop into seizures. Kind of as I mentioned, it can be a lot of different medications that can cause this. You know, DKA, sepsis, amiodarone is a common drug that a lot of people are on that can kick this off. And then if they've got a new thyroid mass that's just spitting out a lot of thyroid hormone, that can also kick them into DKA. These are some of the lab tests we look at. You know, the TSH, if you guys remember TSH and T3, T4, this is like our normal thyroid panel. And really the thing to note here is our free T4 and free T3 are high, right? So we're overproducing here. And actually that works on a negative feedback loop to have to tell the pituitary and the hypothalamus, hey, slow down, don't produce as much TSH. And it's doing that. So your system's working right, but you can see at the very bottom, we're still producing too much thyroid hormone, probably from some other, whether it be a mass or them taking some medications. Really, what our management is once they hit the ER is going to be stopping the peripheral effects of it, blocking kind of our production of the thyroid hormone and preventing any further release. Rebel Reviews, this is a group out of Canada that I love following their stuff. Or no, they're Australia, sorry. Really our basis is going to be getting propranolol, esmol, some kind of beta blocker on board early. What that's going to do is help stabilize that cardiac membrane, prevent some of those prevent some of those cardiac arrhythmias, but also is going to help decrease that peripheral conversion of the thyroid hormone. PTU and methimazole are other things we'll give in the ED just to kind of help stop thyroid hormone production, and then giving things like iodine, steroids down the road. Usually I'm just titrating this propranolol to effect just until I get them slowed down enough that I'm comfortable. So our last case for the morning, 65-year-old female, nursing home patient. She's here, altered mentation, bradycardia. She's got a history of a couple strokes, hypothyroidism. She takes aspirin, takes her Synthroid. Nursing home has no idea what's been going on for the past couple days. On exam, you know, check her pulse. It's slow. She's about 41. Blood pressure 70 over palp. She's super cold to touch. Minimally responsive. Maybe she's kind of groaning at you every now and then. You know, you're thinking about intubating her, maybe waiting a little bit. What this can be is something called myxedema or myxedema coma. What this is as opposed to the thyroid storm, right, which is where we're slamming on that gas pedal, everything's moving really quick. This is the opposite, where the gas pedal's gone. We're not getting any throttle. Extreme hypothyroidism. So you get this hypometabolic state. So they're cold, they're slow, they're bradycardic, they're breathing slow, they're hypotensive, shocky, altered. Problem is, this is a lot of the patients I feel like we pick up from these nursing care facilities, especially when they're older, you know. And did they take too much of their beta blocker? Did they take too much of other meds that can kind of be driving this? I put the pitting edema on here, which, you know, unfortunately, especially here in Birmingham, we see a lot of patients with edema, right? These guys will have edema everywhere. It'll be on their feet, in front of their tibias. You can see it on their face and underneath their eyes. They'll have kind of pitting edema all over the place. Let this kind of increase your suspicion for it. You know, your initial treatment for these guys is, well, they're low on thyroid hormone. Well, let's give them some thyroid hormone, right? Let's try to hit the gas pedal a little bit better and get them supported. But other than that, you know, the treatment for this, at least until we can get some thyroid hormone on board, is just supportive care, right? If they're not breathing adequately, well, maybe you need to take that airway. If they're hypotensive, get some fluids on board. Go ahead and start some pressors. See if we can support them from that standpoint. You know, if they're hypoglycemic, getting some sugar on board. So kind of coming back to basics as far as initial management of these guys. But one of those that is easy to miss if you're not thinking about it, and patients can have really, really bad outcomes. So I know that was kind of a whirlwind, kind of going through a lot of stuff. What questions do y'all have right now? Chief Ward, any questions from online?
Yeah, we got a couple. So I think most of the questions we've had have actually been about adrenal crisis.
Mhm.
So we've got a state protocol for adrenal crisis that involves Solumedrol.
Mhm.
And I think most of our questions are revolving around, hey, how does Solumedrol help? What's the mechanism?
Yeah, and so what Solumedrol does is you kind of get a mix of this kind of mineralocorticoid and glucocorticoid. So really what it is it's artificial cortisol, kind of acting on two different levels. And kind of similar to the hydrocort that I kind of reach for in the ER is really what we're trying to do is just replace that cortisol, because your primary problem is they're not producing enough cortisol either at all, or they're just not producing enough for that stress state. So it can be definitely helpful. It's one, I think one of the more important things to get on board early.
All right, good deal. Yeah, we had a few questions related to that. We also had one person ask if you thought it would be a good idea. I think I already know the answer to this, for us to carry insulin in the pre-hospital setting. And I think shelf life and other things probably.
Yeah, I think that's the problem is, like, on one hand, logistically, insulin can be difficult to keep up with. It can be very expensive. A lot of times, that insulin in the moment isn't going to be the thing that really saves these guys before we can get to definitive care. I think a lot of times we're really supporting them as best we can before we can get to, because we're not going to be treating DKA or HHS completely out in the field. It's one of those, it's going to take days and it's going to take a lot of resources. So really kind of the more we can kind of stabilize them in the moment and get them to definitive care is probably going to be better.
Yep. So another question is, we've traditionally been taught that lower concentrations of dextrose is better for children who are hypoglycemic.
Mhm.
And what's the rationale behind that, if you know, or if you could?
Yeah. This is kind of me spitballing, but I think a lot of times in these little kids, their vasculature really doesn't tolerate those really high concentrations as well as older people do. If you think about it, you're giving a very thick and a very kind of irritating substance in the veins. If you're giving it in a large vein, say in like an adult-sized human, you can probably, you can get around that a little bit and they can tolerate it better. In those teeny tiny little veins that we get on kids, you're probably going to give way too much glucose, and it's probably going to be just really, really irritating to the vasculature there. You can get away with D5, D10 just fine with these little kids.
All right, very good. So a couple more things related, I think, primarily to diabetes. One is, if you have a patient with altered mental status, at what glucose level do you kind of attribute their altered mental status to hyperglycemia?
So, man, hyperglycemia, that's hard, right? Because a lot of the times the glucose isn't really what's driving it. Kind of as we were talking about before, it's the glucose typically isn't the problem. It's either in HHS, it's that they're just so dehydrated and that blood is just syrup, versus in DKA, it's because they have so many ketone bodies floating around that maybe they're starting to get some brain swelling. So I don't know that I would necessarily drive it off of the glucose level, as I would kind of the clinical picture of it. And in the pre-hospital setting, especially, I would kind of preferentially reach for kind of some fluids before we're getting to kind of really hammering down that diagnosis.
Yeah, I think part of what they're getting at here is a lot of times we'll have somebody with altered mental status, we really can't figure out what's going on with them.
Yeah.
And you do a D-stick and it's 280.
Yeah.
And I think generally speaking, from my experience, from my point of view, is I'm not going to attribute the primary cause of altered mental status to hyperglycemia until it's super high.
Yeah, absolutely.
Otherwise, I'm gonna keep looking for another cause. Would you agree with that?
No, yeah, completely. And that's the hard thing, especially with our patient population here, is there's a lot of people just walking around the streets with blood sugars of 300, 400. So it's, it's helpful. Blood sugar is one of those. It's helpful if it's 40, and it's helpful if it's 1,000. But kind of that in between area, it's difficult to really hang your hat on.
Yep. All right. One more. It's related to metabolism too. It's an interesting question. So a lot of people are currently on super low carb diets and becoming ketotic purposefully, even measuring it every day and that sort of thing. Through restriction of dietary carbohydrates, is it possible for people to create any type of medical emergency due solely to elevated ketones?
Yeah, that's a difficult one. It's in the setting of a normal insulin axis, in the setting of normal glucose metabolism, it's hard to get into ketosis enough to really throw yourself into a medical emergency unless you're just severely starved. When we get into trouble is if you've got someone who is already very insulin resistant, if they're a type 2 diabetic, or if they're a type 1 diabetic trying to do these, where kind of like we were talking about before, what you need is you need a deficiency within the system itself and then a stressor on top of that. So I would think of the low carb diet as a stressor, but if you've got a normal intact system, it's going to be much more difficult to get into a medical emergency kind of in that setting. Not to say that it's impossible, but much less likely.
Very good. Excellent. Hey, appreciate the great lecture, Dr. Wade. Appreciate Dr. Hubbs for the earlier lecture. Just a reminder to everybody, please fill out one of our attendance forms. There should be a link if you're online that you can click in the Q&A box. The past password is renal. If none of those mechanisms work for you, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form. Thank you very much for joining us. We'll see you in 2 weeks. We'll be coming to you from Albertville, if I'm not mistaken, 2 weeks from today. So look forward to seeing everybody then. Take care.